Good morning, good day, and good evening, wherever you may be. Welcome to this FIP digital event titled Pharmacists' Contribution to HIV Prevention, Screening, and Management. Let me introduce myself. My name is Sham Woodley, a community pharmacist based in Durban, South Africa, and a FIP CPS EXCO member. I will be your moderator for this very important session, and I assure you we have a panel of amazing experts for you today. So there are a few housekeeping announcements, and we're going to go through that now. This webinar has automatic subtitles available in Spanish. The recording will be available on our website at events.fip.org. You may ask questions using the chat box or the Q&A box. You're welcome to provide feedback to webinar@fip.org, and your feedback is always important to improving the standard of our presentations. You can also become a member of FIP if you are not already one, and this you can find on fip.org.membership registration. So the recording obviously will be provided after the event. So if you can avoid taking photographs or recording it yourself. Let's move on to this part of it, which we're quite excited about, in the fact that we have this QR code, which if you scan now and open a parallel box, it'll allow you a translation in Spanish. Gonzalo will put it in the chat box, methodology of how you should do that. If we can move on. This, as I said, is an important day. The 1st of December each year creates an opportunity for people around the world to unite in the fight against HIV, show support for people living with HIV, and to remember and commemorate those that have died from HIV and AIDS. It has been 34 years since the founding of World AIDS Day in 1988, the very first ever Global Health Day. Globally, there are 38 million people living with the virus, and more than 35 million people having died from HIV or AIDS-related illness, making this the most destructive pandemic in history. Today, scientists, and particularly our pharmaceutical community, advanced the treatment of HIV and provided access to more informed and much deeper understanding of the disease to some extent. So in terms of availability of testing, as well as diagnostic and treatment options, combined with appropriate pharmaceutical care, renders this a chronic condition rather than a life sentence. World AIDS Day each year provides FIP the opportunity to showcase the progress that has been made in our One FIP approach, explore the great work done by member organizations, and identify and learn from best practice models made available by the FIP family across the globe. We'll move on to our agenda now and just describe what we're going to see today. So we open with the presentation of the FIP toolkit that we've been designing for the last year. And this will be done by Ruben Viegas. We will then have the opportunity afterwards to meet and engage in a Q&A session with our panel of experts representing 6 different member countries and practice settings. And I will go through them and introduce them when we get to that point. Let's look at the learning objectives for today. There are 3 major learning objectives that we would like to achieve. The first being the understanding the role pharmacists can play in HIV prevention, screening, and management, recognizing some resources and tools that pharmacists can use in this area, and then find and use the FIP toolkit on HIV prevention, screening, and management. So let me move on then to our first speaker for today that will present the FIP toolkit. And this is Ruben, who's the FIP Practice Development and Transformation Project Coordinator. Welcome to the floor, Ruben. I hand this over to you now.
Thank you so much, Shem, for the nice introduction. And it's a pleasure to be here today presenting this new resource. And it's now available for all of you to find and consult on the FIP website. So we have this HIV resource that focuses on different roles that pharmacists can have in supporting people living with HIV, focus mostly also on prevention, screening, and management as three big categories. So as you can see on your screen, you can reach the link on the screen that will probably one colleague will also post in the chat box, or you can scan the QR code. And you can see that we have this resource now available on our website, which is closely related to one of the development goals of FIP, which is goal 16 that you can see on the cover in the communicable diseases. And you can also read more about this goal on the FIP website. FIP would like to thank all the authors, all the reviewers, all the members that invested their time and effort to provide inputs to this publication, to review, to provide more case examples, different experiences, and share, because FIP is house a table for this kind of work to happen. And it's great to have a global picture and sharing best practices among all of them. So again, thank you very much, everyone that was involved in this publication. Of course, the first part of the publication, the first chapter, I'll go through the main chapters. The first one is the introduction, and I think our moderator already set the scene very well and explained why is this important, because pharmacists can be part of this in tackling this pandemic and this epidemic. So they can support, for example, the goals that we have here by 2025, reduce less than 10%. Stigma, discrimination, gender equality, violence. Pharmacists can do that in their communities, and they can also support the other goals that we see on the right side, the 95 goals to increase the percentage of people with HIV that they notice that they start the treatment, they are virally suppressed and they can have a normal life. So this first chapter of the publication has a description of the disease burden, the goals, the main risk groups, and it highlights the following sections. So as I said before, prevention, screening, and management, and then in the end, also a chapter on the pharmacist's impact in the community, which is also very important for the engagement that they can do and the change that they can have in their communities. Focusing on prevention, we have different blocks, as you can see on the right side. So we have sexual health, including safe sexual practices, for example. We have a subchapter on pre-exposure prophylaxis as a very important tool, and post-exposure prophylaxis, and also another one on harm reduction practices. And you can see on the upper right side that according to the WHO, pharmacists and pharmacy teams can play a crucial role, for example, in the provision and monitoring of pre-exposure prophylaxis. So, and there are also some resources from the WHO that focus specifically on pharmacists, and they are available in this publication. And then on the left side, you can see some of the combination HIV prevention approaches that will for sure be discussed during the panel discussion. So I'll not go through them, but you can have the biomedical ones focusing more on condoms, for example. In the community. The next big block is the screening one. So we have different types of testing. So the testing in the pharmacies with the healthcare professional, or the self-testing that can be done at home. And also pieces of information on how the pharmacist can deal with the test results. Because sometimes someone can do a test, and if it's positive, the pharmacist should be able to counsel and to advise what are the next steps and what does the test mean. And then, for example, we have different types of testing, and you have antibody test, antigen. So there's a different ones, how it is done, some information on the window periods. So pharmacists can have an overview on a different type of testing, and how they can support testing as one of important role. The following block, the following chapter focuses a bit on management. And here, pharmacists are the medicine experts. So of course, they can provide support in different aspects. So the administration, for example, the adverse effect management, the interactions that these medicines can have, the care plan, so following up, also the evolution of the condition, and clinical monitoring that can be done also in different markers. And then we have another subsection focusing specifically on the HIV medicines management, and also focus on adherence, which is very, of course, very, very important to ensure that the clinical outcomes are reached. And the image is very obvious, but it's very important that these people take their medicines so they can have a sustained valusuppression. They can have a better a reduced risk of drug resistance, better health outcomes, improved quality of life. They can live normal lives, and they also can decrease the risk of transmission. So the management aspect, the chapter is also quite important, because pharmacists can have a significant role here. Closer to the end, we have another chapter that is not less important, but it's also focusing and explaining the pharmacist's impact in the community. So it's divided into public health campaigns, community awareness and advocacy, the stigma and mental health aspect, and the sexual violence. So these are the three blocks, or three ideas, three groups that pharmacists can be more informed and have an impact in the community. And we have, for example, a table with different public health campaigns and the focuses. For example, the one that we have today, the World AIDS Day, that is a reason for pharmacists to join this campaign, to share materials that are, you can see on the FIP LinkedIn page, for example, and you can share. So this is also joining the movement and raising the voice of pharmacists across the globe. Finally, we have a section with additional resources. So we have the main global organizations, and also, as I said, for example, we have the module 6 for pharmacists from the WHO, pre-exposure prophylaxis. So we have all these resources linked to the publication. So you can go there and you can read more, and also go through all the resources that are already produced in the different organizations. So this is a global overview of the resource. It's available for you, so go ahead, read it. And if you have any questions, you can always contact the FIP staff through our emails. And I hope you have a very good panel discussion, and I think the outcomes will be for sure very interesting. So thank you so much, and Cham, back to you. Thank you.
Thank you very much for that, Ruben. I think there's a lot of detail in this project, and I'm sure the different countries that will be utilizing it will find amazing use out of the different aspects that have come out from the various countries that we managed to put together in this document. So it just also leads us really nicely into the next part of our discussion, which really what we did with this is try to strategize it around table discussions. So I'm going to throw a few not too difficult questions, I hope, to our panel, and we will go through and try and answer them for your benefit. And out of that, there would be some of the projects done in these various countries that will be highlighted, and you will have use of that valuable information too. So let me go ahead and then introduce my panel today. I'm starting with Ali Ahmed. Ali is a PhD candidate in clinical pharmacy at the School of Pharmacy in Monash University in Malaysia. My next person, that's Dr. Alicia Kruger, who's a clinical pharmacist at the Federal Council of Pharmacy of Brazil. Thanks for being here, Alicia. Next is Dr. Elise Haro-Brunet, who's a pharmacist at CESPharm. It's a French chamber of, a part of the French Chamber of Pharmacists. Next, we have Professor Romeo Angpoy, who was part of CBS as a volunteer and in the Philippines. Next, we have Dr. Catherine Albed, who's assistant professor at Fred Hutchinson Cancer Research Center in the USA. And last but not least is Hamish Bowden, who's senior clinical pharmacist, HIV and sexual health at the Albion Center, North South Wales Health in Australia. Thank you for being here, panel. I'm then going to move on and maybe start off with what Ruben discussed and pose a question in terms of what each of the countries can contribute to and how they manage it. So my first question to the panel is, how often do you encounter people living with HIV/AIDS in your daily practice? And what are the main enablers to start a conversation in this situation? I'm going to invite everyone to put on their mics and their cameras so that we can see you. And I will start from the top of my screen and look at first. Ali, would you start with that, with your contribution to that question from your country? Thank you.
Okay, thank you so much, Shyam, for inviting me. Basically, I am from Pakistan and doing PhD in Malaysia, and my whole PhD research is focused in Pakistan. And before starting my PhD, I was working in National AIDS Control Program of Pakistan. That was like, I was based in antiretroviral therapy center in Pakistan. And like the normal procedure in Pakistan is like that whenever patient come, we first do the introduction in our local language, that is Urdu or Punjabi, whatever patient has a local language. We try to communicate with them in their very basic local languages. And after that, we try to console them, because once the patient comes, it's lot of worried that what happened, like he thinks that he is dying, like he will not survive. What will happen to his family, his dependents? So first of all, we try to console them. Then like a nurse try to tell them this disease is it's just like a diabetes, because many people know diabetes, it's a chronic disease. If they can take medication, they can be settled. So after the nurse, the health counselor, then comes the physician in Pakistan. That physician actually do then more counseling. Then comes the pharmacist. Like in the first 2-3 sessions, we do the counseling for 1 week before starting any therapy. Then after that, when patient is ready and we note his like every details, his phone number, his home address, in case if he do not come next time, so we can follow up. So after doing that, like I was pharmacist, like my main duty was to tell the patient that this medication is very helpful. It has very lesser side effects. Like if you take this medication regularly, daily, your health will be improved. You are all comorbid conditions, like mostly patient have a TB, hepatitis C, other comorbid conditions. So I tell them, if you take this medication, with the passage of time, all of your symptoms, comorbid conditions will be reduced. So it's overall like another like behavioral techniques we use, and some like pictograms, like different diagrams we share with them, like past patient experiences, like when the patient came, he was like in ICU, but after taking regular medication, it start recovering. So anyone other?
Thank you very much for that, Ali. Alicia, Ali has outlined quite a few strategies that they have. And maybe from a Brazilian point of view, can you maybe look at the issue of local languages, this multidisciplinary team that Ali is talking about, the counseling techniques that he's mentioned, and some of the behavioral matters as well. So Alicia, the floor is yours.
Thank you so much. First of all, we'd like to thank you so much on behalf of our Federal Council of Pharmacy of Brazil. I really would like to thank you all for the opportunity to be here today, and also to the opportunity to build together the HIV toolkit for pharmacists worldwide. I think it's a great strategy for us worldwide to be to get more and newly strategies to new approaches. So I totally agree with Alice said, because we need not only to talk and to think about medication. We are not a professional just related to medication. We need to be more welcoming, not only with the people living with HIV, but also the people that are more likely or more vulnerable to acquire HIV. For example, here in Brazil, transgender women and travestis are the most likely people to acquire HIV, not only because of the sexual behavior, but our country, for example, is the country that most murders transgender people worldwide. It's not a good news, but it's a real news. We need to fight against prejudices as well. We as pharmacists, we are the professionals, we are we are closer to the patients in every pharmacy we have in every corner of our country. So I think we have different strategies to better approach people living with HIV and the most vulnerable populations. So Brazil has a very specific framework, because we have the greatest, I think the biggest healthcare system worldwide, because we have a public and totally free of charge health system with over 2,000 million people using this healthcare system. So here in Brazil, we are allowed to prescribe PrEP in São Paulo City, and São Paulo corresponds to more than 70% of the pharmaceutical prescriptions on PrEP and PEP as well. So as I said, we don't have only talk about medications prescribing PrEP or PEP. We need to talk about the soft skills we pharmacists we need to have to better approach and to be more welcoming with people living with HIV. For example, in my daily practice, I'm used to face day to day a lot of people that are really frightened about not only to acquire HIV, but to experience the day-to-day prejudices. Because we know that the virus is not only the great cause of death here in Brazil and worldwide, but the prejudice is the main cause of death worldwide. The prejudice, the burden of living with HIV is still very, very big in Brazil and worldwide. So we pharmacists, we need to have soft skills. We need to have a lot of different skills to better approach and better welcoming patients worldwide. And I think it's better, it's easier to us here in Brazil because we have a huge public system that allow us to have a great role in different points of the line in care, the care line of HIV in different points and different systems and different services here in Brazil.
Thanks for that. I've picked three issues up here. The first is the faith-based that you talked about. The second is, I think, really in keeping with the theme of this year, which is equality, the treatment of women and those that are struggling with the gender-based violence, for example, the treatment and getting equality across that, and then the trying to integrate skills in pharmacy. So let's move on to then to Elise, who's in France. Elise, if you can maybe comment on some of that and any additional issues that you feel that will be useful to our panels and our audience today. Thanks, Elise.
Sorry. I can say that it varies greatly depending on the place of practice. In France, we have a particularity. Antiretroviral treatment can be provided in hospital or in the community pharmacy, depending on the patient's wishes. This double circuit was chosen at the beginning to preserve patient confidentiality. For my own experience, I worked for a long time in Paris and very close to many hospitals and prescribers. I then had about 10 patients living with HIV and 15 patients on PrEP. For the past year, I've been working in a more rural area facing a major medical desert, and I know I've about 10 patients living with HIV, but only 2 patients on PrEP. The pharmacist can play a major role to start a conversation with these patients. We can, pharmacists can inform public through awareness campaigns. For 1st of December, for example, we promote, we deliver condoms. We can deliver the PrEP, pre-exposure prophylaxis. Since 2017 in France, we can deliver steering materials for injecting drug users. And for information, in France, more than 10% of pharmacies are involved in a Serang services program. So it's a very good thing. But to start the conversation, the best way is the prescription, is when we deliver the treatment.
Thank you very much for that. Let me then move on to Prof. Romeo Angpoy to look at what's happening in Philippines and their experience with the day-to-day management of patients that are HIV positive and are using ARVs. So, Prof, you next on the floor.
Hello, it's nice to be here. It's nice to be back here in FIP. So in the Philippines, by the way, I actually, while working in the academia, I also volunteer for community-based screening in HIV. So I do that for research purposes. So community-based screening in the Philippines is when we go to the patients and we accompany the patients throughout the continuum of their treatment for HIV, and also for testing so that they will know if they have HIV or not. Now, Philippines is actually one of the most cases of HIV, and it is fast growing up to around 8,000 to 50,000 in 2017. And as of now, it's really the most fast growing in Asia, and probably one of the most in the whole world. And this is the CBS program is actually one of the tools in order to bring the testing to the people. So we actually do testings in several locations, whatever is convenient to the patient. Because the problem with testing is that these clients are actually, we call them clients, not patients, in the Philippines. So they are actually scared, and to minimize that particular feeling, we actually go with them in order for them to get tested. And if they test positive, we actually go with them to this particular clinics that we call hubs in order for them to seek treatment. If, for example, they are negative, what we do is to connect them to safety by giving them PrEP, which actually just been distributed in the Philippines around 2 years ago. Now, the problem in the Philippines, I guess, is that there is actually not much pharmacists who participate in the HIV treatment. And I guess this is because of the problem with stigma. And stigma is very, very rampant in the Philippines, even among pharmacists and healthcare workers. So in my own opinion, I guess we need a lot of work here in the Philippines to minimize the stigma first. And then after minimizing the stigma, I think the plan for testing at bedside, testing in the pharmacies would actually be feasible. But as of now, in my own opinion, stigma would better be addressed before doing pharmacist promotion with HIV. Yeah, thank you.
Thanks very much, Prof. I'm going to move on to Katrina to look at what is happening in the US. And I know that there are some super models of care in various different provinces. And they're all a little bit different, how they're administered, what the regulations are. So can you tell us how, from your point of view, these patients are being managed and some of the work being done? Thanks, Katrina.
Yeah, hi, thanks so much for having me. I'm Katrina Orblad. I'm from the Fred Hutch Cancer Center in Seattle. And actually, I can speak better to some of the work that's happening in Kenya, because most of my research has been working in collaboration with a number of Kenyan researchers from the Kenya Medical Research Institute, Jomo Kenyatta University of Agriculture and Technology, and JPIGO for the past 4 years to develop a model of pharmacy-based PrEP prescribing and dispensing that is based off of models that are ongoing in the US. So we based this model off of a model of pharmacy-based PrEP prescribing that is happening at the Kelly Ross Pharmacy in Seattle. And this model works through pharmacy providers using a prescribing checklist to identify clients that are unlikely to have any medical conditions that might contraindicate PrEP safety, and then prescribe PrEP using this checklist with remote clinician oversight, and referring clients that don't meet the criteria on the checklist to facility-based care services. So we have taken this model of pharmacy-based PrEP prescribing that is ongoing in the US and adopted it for the Kenyan setting, and have been pilot testing this at a number of pharmacies in Kenya, and have found that this is really reaching populations in need that could benefit from PrEP services. I think when you look at, going to this issue of stigma in Kenya, as well as a number of other African countries, most HIV treatment and prevention services are being delivered at public facilities, as well as a few faith-based facilities and very few private facilities. But there's a lot of stigma associated with accessing HIV care and treatment and prevention services in those settings because they're often delivered at HIV clinics. So especially when you look at prevention services, people that are not living with HIV are not interested in accessing care in those settings, which is why we're really excited about developing these models of pharmacy-based HIV prevention service, where pharmacists can directly provide HIV prescriptions for PrEP with remote clinician oversight. So thank you.
Thanks, Katrina. I think what's coming through is that, especially in the Philippines and some of the work that you are doing in Kenya, for example, is that a lot of this work is being done by faith-based or public or volunteer organizations without much participation from pharmacy. So I think this is a really good discussion to be having, in that both the tools and some of the experiences from the different countries can be utilized in different environments now to try and advance the role of the pharmacist. So I'm going to move on to Hamish to look at New South Wales and his experience as a clinical pharmacist, and maybe he can give us some guidance on how they're managing to mitigate the HIV pandemic in their own country. Hamish, up to you.
Thanks, Jam. So I actually work in a government-funded sexual health service, and about half of my clients are living with HIV, which equates to about 1,500 or so. The majority of these clients actually see HIV specialists within our centre, but we also see clients who have, I suppose, their HIV and other healthcare needs managed by general practitioners and other sort of sexual health and infectious disease specialists. Over the last 40 years or so, we've actually done really well in Australia, I suppose, reducing the amount of HIV diagnoses initially and the spread of HIV back in the 80s. We had some horribly effective, but actually horribly stigmatizing TV campaigns, which worked very well, but people are still stigmatized by them 40 years later. So anyone over the age of 40 still remembers these horrible ads of the Grim Reaper, using like basically in a bowling alley, knocking down women, children, anybody, and basically saying, yeah, HIV can affect everybody. Over the last few years, or probably the last 10, 15 years, most of our messaging has been targeting, I suppose, white Caucasian MSM. And we've actually had the lowest number of diagnoses last year since the beginning of the AIDS HIV pandemic back in the 80s. So we're doing really well in white MSM, but we're not doing very well in the COLD communities, the culturally and linguistically diverse communities. So migrants have moved to Australia. We're not doing very well in our Indigenous population. Rates are going up in the heterosexual community, especially in men and women over the age of 50. And again, like spoken before, the trans community is very much affected by HIV. We really need to change our messaging and targeting to encompass everybody now, and not just the white male who lives in the inner city and has a lot of fun. It's been very effective, but it is quite, we need to broaden the scope of it. But yeah, I mean, it is difficult, I think, everywhere, but we have been quite lucky and fortunate in Australia. We introduced needle exchange programs back in the early mid-1980s, which did stop a lot of the spread of HIV, especially into the heterosexual community. So it did actually work really well. I mean, most of my patients, I've been looking after them for 8 years or more and have great relationships with them. Anyone newly diagnosed today, I sort of feel my heart, because it's like, there's so many wonderful prevention measures available these days. And for someone to be diagnosed, I think is still very challenging, even though we know that living with HIV, if you're diagnosed and commence treatment early, you should live a long, happy, active life. And that's something I always tell somebody who's newly diagnosed. You know what, you go on treatment, you commit to treatment, and your life expectancy in Australia is roughly the same as your equivalent matched non-HIV person. You're involved in healthcare. You'll have your blood test done every 3 to 6 months. Any medical problems that occur will be picked up early and will be looked after. So we are quite fortunate. But yeah, there's still a long way to go though, even here.
Thanks for that, Hamish. I think the two main issues that are coming through from all the speakers is that we'll tackle a little later. Is stigma is one, and the next one that we want to move on, and Hamish, I'm going to keep you on the screen there to look at the issue of prevention strategies within your country. You have discussed some of them, but just maybe some of the success stories that you've had personally, and as maybe some of the associations in your country that have put forward some good strategies. Maybe if you can start to discuss that, and we'll move to the other countries and look at the issue of prevention and some of the strategies that we need to be aware of. Hamish,
yeah, so like others mentioned, we have post-exposure prophylaxis for people who've had an exposure risk within the last 72 hours. We also have PrEP. Both of these are available only on prescription though in Australia. Though any general practitioner can prescribe PrEP, and most pharmacies, if they don't stock it, can order it in. Where I work, we also really support and promote the U equals U, or undetectable equals untransmittable message, which states that someone who's on treatment with an undetectable viral load cannot transmit virus to their sexual partners. This is an amazing campaign, and I think it's reduced a lot of stigma within the HIV community, as well as people feeling stigmatized by others. There's a lot of internalized stigma for people living with HIV, feeling that they may be at risk of passing the virus on. And this campaign has been very, very important. And I tell all my clients about it, whether they're living with HIV or they're not. And it's eye-opening for many of them. They just haven't heard about it. And I find it extraordinary in many respects, because we've been bashing everyone over the head with it for a number of years now out here. But again, unless I suppose you're in that demographic which sees that promotion, you don't know about it. So I told everyone about it. I told my friends, I told my family, I tell everybody about the amazing advances that have been made in this area of prevention, because it's so important for stigma. I don't know, I think we're doing really well. I myself are involved in a number of, I suppose, peer groups and non-government people living with HIV groups. And we have forums where I'm there as the pharmacist answering questions from the audience. And they can be about anything, whether it be HIV or other health-related issues. Over the last couple of years, it's been dominated by COVID and more recently NPOX. But it's great just being out there in the community and talking to people and allaying their fears, answering their questions. It's a great, there are many great organizations here, and I'm really happy that I'm involved with them.
Thanks, Amish. Katrina, maybe I can come to you around the issue of prevention and some of the strategies that you're involved in Kenya or any other parts of the world, and maybe something that's happening in the US around prevention that we need to be aware of. The floor is yours, Katrina.
Yeah, thanks so much. So in Kenya and in many parts of Africa, the approach has really been combination prevention approaches. So there's the biomedical interventions that pharmacists are familiar with. So PrEP and PEP, and treatment as prevention, as Hamish was just talking about. But then I think there's also, the other interventions. So emphasis on increasing HIV testing so that you can link people to early treatment and prevention services, as well as a lot of counseling and education on behaviors associated with HIV risk, like multiple sexual partners, partners of unknown HIV status, engagement in transactional sex, condom distribution campaigns, voluntary medical male circumcision, which is still one of the best interventions that we have in the HIV prevention toolkit, as well as emphasis on prevention to mother and child transmission. So I think it's really, there's no silver bullet, especially as we look ahead to newer and more effective forms of PrEP that are going to be longer acting, which will be available soon in many African countries and are already available in Zimbabwe, cabotegravir, which is a bi-monthly injection. But I think it's really going to be this combination of different prevention strategies to help keep people HIV unaffected. Thank you.
Thanks, Katrina. Prof. Romero, any additions to the strategies that is currently being put forward by the other speakers?
In the Philippines, aside from CBS or community-based screening, we also employ this strategy in which we take care of the mental health of the patients. So there are programs for mental health that comes in series so that the HIV people will be prevented from harming themselves, because that's also very common and there is no documentation on that. Now in the Philippines, 67% of the people who are infected with HIV, they know their status, but the rest of the 30+% don't know. And usually this 86% of this are MSM. So, and as a Christian country, in the Philippines, homosexuality is a taboo. So there are actually very much problem on that. That's why you need to reach out on them, and you also need to nourish their mental health, because although there hasn't been anything published, but there are actually some who commit suicide, and that is actually just very sad. And we actually need more pharmacists to help in CBS programs, because as of now, the pharmacists are only involved in inventory. So to be honest, I don't know any other pharmacist who conduct community-based screening in our country other than myself. So the involvement of pharmacists is mostly on inventory setting, but it would be nice if there will be more pharmacists to be involved, but I think there will be more if I've said before that it is because of stigma, but another thing, because there is not much information drive. When I say not much information drive, there is no information on how to, where to get PEP if in case there is an accident, you get pricked on when you are actually testing the patient. So that actually poses a very considerable threat to our pharmacists here in the Philippines. Thank you.
Thank you very much, Prof. At least maybe we should move on to the issue of PrEP and PEP, which has been mentioned quite a few times in different countries. Let's try and explore which of our countries then have pharmacists that are allowed to prescribe and dispense both PrEP and PEP. I know somebody mentioned the fact that I think in Australia, you probably need a prescription before it's done. So can you look at it from your country point of view, and maybe we'll ask the other speakers as we go along in terms of what their countries do in terms of PrEP and PEP and pharmacists being able to prescribe and regulations. Also, if there are any barriers to it, maybe you can talk about what would be the enablers that we need to look out for. So over to you, Elise.
Yes, thank you. I can say that in France, we have PrEP, of course, and with the pandemic, the prescription by physicians has been opened since 2022. All physicians can prescribe PrEP, and not only hospitals. This simplification was eagerly awaited by patient associations. In France, pharmacists can't deliver post-exposure prophylaxis without prescription, and not in community pharmacy, only in hospital. But the government, the Ministry of Health, is very attached about this measure, and in the roadmap for the National Sexual Health Strategy 2021-2024, published in December 2021 by the French Ministry of Health, the possibility for the pharmacist to deliver the post-exposure prophylaxis will be implemented by the beginning of 2024, and we are very happy of this. Also, there is nothing committing today. The French Chamber of Pharmacists will be in favor of allowing patient association or other health professionals to come and carry out screening campaigns in pharmacies, because it's forbidden now in pharmacies. And I would like to say in France, clinical biology laboratories screen free of charge without prescription for everybody. So since 2022, everybody can go in clinical biology laboratories and make a test. And I would like to add yes, in France we have another particularity. We have pharmaceutical teleconsultations and pharmaceutical interviews with patients, and we have other missions assigned to pharmacists, such as vaccination, and in particular against hepatitis B and human papillomavirus in our case. And pharmacists can assume that the link with these patients will be strengthened, and these advances will position pharmacists as a major player in the prevention. Yes, and it's okay.
Thank you very much. Let me move on then to Ahmed Ali. Ali, in your country, are pharmacists allowed to prescribe and dispense PrEP and PEP? What's the situation there?
Okay, first of all, PrEP and PEP are recently approved by Pakistan last month. So it's a very new thing for us in Pakistan. Like, and these in Pakistan, mostly drugs HIV program is run by a government sector. Private sector is not involved. So everything is done through government hospitals. Even in government hospitals, I was the first pharmacist hired by the Pakistan government. There is no pharmacist involved in HIV in Pakistan. Actually, first to understand this thing, you have to, because every country has a different demographics. Pakistan mostly has, in HIV trend is growing in Pakistan recently. if you go 5 years back, there was very less number of HIV patients, but nowadays it's spreading very high. But in other countries like in Africa, in US, in Australia, the trend is downward. But in Pakistan, as Romeo also mentioned that in Philippines, the HIV trend is very high. Same Pakistan is second after the Romeo country, that is Philippines. So actually we have a very, like I am very impressed by the Katrina and Alice. They mentioned that they are using very advanced behavior and biomedical and health technology approaches to engage the patient. But in Pakistan, we are in very nascent stage, in the initial stages. So we don't have these things, but recently we have approved the PrEP and PEP. First of all, if we want to decrease this rising trend, in Pakistan, mostly HIV is spread through quackery, medical malpractices. If you read about, if you type on Google, you will find that in Pakistan, 800 children got HIV, very young children, like 1 year or 2 years children get HIV. Through the child specialist, he is using the same syringe and spreading the HIV to many people. So we have a lot of clusters of new HIV outbreaks in Pakistan. So if we have to change in Pakistan, we must have to go towards the healthcare professionals first, like the doctors, the nurses. We have to improve their practices, to tell them, to educate them first. Then we can go to PrEP and PEP. Secondly, in the bad thing that happened in Pakistan is that we in our syllabus, like 9th class and 10th class, we read that HIV is spread through sexual contacts, homosexuality and heterosexuality. And when we grow up, all of us, we think that HIV is spread only through sexual practices. But in reality, in Pakistan, HIV is mostly, more than 50% cases, it's spreading through quackery. Secondly, it's spreading through people who inject drugs. Third, it's spreading through the transgenders. Then comes the MSM and FSM, female sex workers, and then come the LGBTQ community. So these demographics are very different. So I hope so in future. Next, I want to add that in Pakistan, all HIV related things are sponsored by Global Health. It's a global fund. Pakistani government is not like funding anything to help the people. So if global fund, whatever global fund say, we do implement these things. So hopefully, I am hopeful in the future, as I am working and another people know, young researchers are working. Hopefully, the things will getting changed, and we will try to take experience from the Africa and US and other countries there. What are they are doing? We will try to implement and try to use their policies best in our countries now. Thank you.
Thanks, Ali. I'm going to keep you on the floor for the next question that I want to ask. But before that, maybe the comment from that discussion is that certainly there is some advances in the fact that there's recognition that pharmacists can prescribe both PrEP and PEP, and some of the countries are implementing. I suppose one of the barriers to that would be, are we adequately trained to do that? So what we've done in South Africa is designed a training program, completed the training of pharmacists to do that, and currently legislations are being passed to allow the pharmacists and give them a certification to continue dispensing both prescribing and dispensing PrEP. And I think that's probably going to be the future of where pharmacy is going to with this issue. So I'm going to keep you on there to look at the screening role then. In your country, what about the screening role that pharmacists play? Do they screen for HIV? Is there screening done at the pharmacy? South Africa has many self-screening tests now. In fact, today, part of the HIV program, through independent pharmacy, there's around 10,000 free kits that are being distributed across the country with knowledge, and pharmacists are doing that. So in your country, what is happening around screening?
Okay, at the moment, like everything is done through the government department. Pharmacies is not involved at any stage in HIV care. Like there is no community pharmacy that is doing screening tests. So if anyone get any symptoms, it directly go to government recognized. There are around 60 HIV centers in Pakistan. Pakistan is the fifth populated country in the world. So in only government setting, but hopefully there are going on talks that we should promote public-private mixed model, that we should involve some big pharmacies, chain pharmacies in this thing to screen more, to distribute this. But presently at the moment, we don't have this screening facility and pharmacy is not involved at all.
Thanks, Ali. Alicia, can I move on to Brazil then? Are pharmacists allowed to screen patients for HIV, either using a test or even in a discussion and maybe a referral system?
Yeah, thank you so much. In Brazil, we are allowed to be part of the screening team. The private pharmacies, they have the self-testing to sell to people, for example. So you can buy your own test and to get tested in your own home, and then you have a telephone number to call to inform your result, for example, and then have all the care you need, for example. But as I said, we have over than 200 million people living in Brazil, and we have a real big health system. And we have all the screening totally free of charge in different services in Brazil. We have the HIV screening in primary care services. We have the screening, for example, to pregnant women and trans men, for example, totally free of charge in the primary healthcare system. We have also, of course, the HIV screening in the HIV-related services in Brazil. We have at least 27, one per capita in the different provinces here in Brazil. And the pharmacies are allowed to perform the rapid tests, the laboratory tests, for example. But I would like to talk again about PrEP, for example. PrEP is available in Brazil since 2017, and PrEP has over 20 years of history in our country, totally free of charge in the health system. And pharmacists are allowed to prescribe PrEP in São Paulo since 2020. And in all the country, we began to prescribe PrEP this year according to a Ministry of Health statement. But the Ministry of Health needed to review this statement because of specific laws here in Brazil. Because in Brazil, the legal prescribers are physicians, dentists, and veterinarians. So we don't have a specific law to pharmacists to be prescribers in Brazil. We have resolutions under legal statements from the Federal Council of Pharmacy, but we are trying to resuming or retaking the countrywide prescription of PrEP. But as I said, São Paulo has over than 12 million people living in there, and it corresponds to more than 70% of all PrEP prescriptions in our country. And São Paulo is keeping pharmacists in there are still prescribing since 2020 because they have a local statement, a local law that allow pharmacists to prescribe PrEP. But I would like to say about one thing that Katrina said. PEP and PrEP are not the superheroes of the prevention. We need to talk about combination prevention. And I'm using to say that PrEP and PEP are the total combination prevention strategy in PrEP and PEP. Because, for example, in PrEP, you can to give counseling to people that are more likely to have HIV, for example. And talking again about the local language, here in Brazil, we have a very specific language called Pajubá. What is Pajubá? Is a LGBT-specific language with a lot of slangs, real funny slangs. But we don't say transvestite here in Brazil, we say travestis because it's a very specific identity here in Brazil. Travestis and transgender women use it to use this Pajubá language in the dictatorship era here in Brazil to escape from the policemen, from the cops. And now it's a kind of funny language because we don't have a dictatorship anymore. But for example, I am a transgender woman. That's the point. We need to hire key population to work with key population. Yes, I'm a clinical pharmacist, but I'm a transgender woman as well. So I know I really know the life of transgender women in Brazil. So when I am talking to my peer, to my sister as a travesti, for example, we talk in Pajubá, and it is a great enabler to us. So what's the motto? Hire trans people to work with trans people, hire gay men to talk with gay men. We have gay pharmacists, we have trans pharmacists. We need to put this kind of persons on the table, on the floor to perform it. The real, we look after to our peers differently. It's not better than you do, but it's a specific kind of approach. So I am very happy to be a trans women pharmacist, and I am very happy to look after to my peers. I am very happy to be here to you today, sharing this kind of approach we have here in Brazil.
Thank you, Alicia. And I think the lesson from there, Ruben, is that we do have best practice models that are happening in various parts of the world. And Alicia, I'm sure that Ruben will be contacting you to write that up as a document for FIP somewhere in our system and publish that. So we'll look out for that. Elise, you seem to be in France, seem to be a little bit more advanced in terms of where you are in this program, and pharmacists having much more rights than many other countries. So I'm going to pose this next question to you, something that we have worked with in South Africa. We've trained around 1,000 pharmacists to do PrEP, PEP, and first-line ARV therapy. We're waiting for regulations to be passed so that they could get their license to practice. Do you think that that is an option in terms of the WHO test and treat strategy to test, treat, and have pharmacists at the same time prescribe first line, for example? Is that a possibility that might happen in your country? Are you reviewing that and looking at it? Elise?
Thank you. Yes, it's a very good idea, but in France, a pharmacist can't prescribe PrEP. It's not a way today to authorize pharmacists to prescribe. The government has opened the prescription to all physicians. It's a first step. But it's not a way to authorize pharmacists to prescribe PrEP, but the government wants that pharmacists prescribe the post-exposure prophylaxis treatment. For the screening, in France, pharmacists send self-antigen antibodies, but the patient has to buy the test, and it's very expensive. In France, the test costs about 30 euros, so it's very difficult for many patients. And in France, pharmacists are not authorized to make, I'm sorry, point of care tests. Pharmacists are not authorized because the pharmacist in clinical medical biology make tests for everybody free of charge and without prescriptions. So it's not a possibility today for pharmacists, community pharmacists, to make point of check. But CESPharm has published No, we can see a document to help the send of self-antigen antibodies to help pharmacists in his mission. And CESFARM has published two, it's not the same subject, but it's not important. CESFARM published a big document to help pharmacists, no, to help pharmacists to dispense PrEP. And this document was built with Patients Association. So it's very important documents for pharmacists. Perhaps in a few years, pharmacists will be authorized to make point of check tests because the government want to improve screening in France. It's a problem. About 20% HIV positive don't know the results of the test. So there are positive and they don't know. So it's a big problem, and the pandemic has had a negative role. The screening has stopped during the pandemic. So it's a volunteer for the government to improve screening. Perhaps pharmacists can play a role.
Thank you for that. Let me put Prof. Ongpoy on the spot here. Do you think that pharmacists, through their undergraduate and maybe with a little bit more qualification, would be able to prescribe first line at any point? I'm going to put that question to you. And the second one, if you can take the question, especially around the reimbursement model in the Philippines, that's being asked by one of the attendees, the question number 3 there. If you can tackle that question for me. Thanks, Prof.
Okay, so pharmacists, if for example they are trained, they can actually dispense medication, but the problem is we don't have trainings like that. So for example, one law in the Philippines specifically says that only those who are licensed medical technologists can do the diagnostics for HIV. But because community-based screening is just screening and it's not a final testing, then there comes a opportunity for community-based screening. And so what happens is pharmacists can really contribute, but there are no specific laws because we cannot just practice and give medications. Another best example for that is that when PrEP is being given in the Philippines, you need a couple of tests, like for example, syphilis, hepatitis, and also it requires creatinine clearance and HIV testing. Now, if you are negative on all that and your creatinine is also good, then you can have your PrEP. But there are also people who are, shall I say, they don't have the money to pay for creatinine clearance so that they can actually get the testing and avail of the PrEP, which is actually given for free in the Philippines in hubs, and they can also be sold for a price for people who wants to buy it. So that is also one of the hindrances. So I guess if we have the right laws that will enable the pharmacies or right guidelines for the pharmacists to contribute in the dispensing of the medication, I guess Philippines can actually do well with HIV. But I stand by what I said earlier, in which we need to remove first the stigma, because this particular stigma is actually very strong. And that is actually one of the first things that I encountered when I volunteered at CBS. So the stigma is that will enable the pharmacists to be discouraged to do HIV testing. And another thing is that you will be dealing with groups of people, and these groups of people are quite actually very small for the PLHIV population, but I think they are small, but they are actually very vocal, and they are actually the loudest. And if, for example, you try to help them and you assist them, they are very vocal on issues like LGBT and also the government issues. And if you try to help them and your idea differs from them or is different from them, what happens is they actually will destroy you. They can actually call your employer. They will actually do anything to destroy you. And I think that actually is a big disappointment. And in my case, when I did the CBS, I am very mature, and my goal is clear to do some research, because there are less research on pharmacists in the Philippines. But if you try to place the young pharmacists in my shoes, I don't think they can survive. You need to have a really strong you need to have a clear goal, and you need to be very mature as well, because the process might actually consume you, and it might come to a point that it will actually destroy you as well. So my stand is actually fight the stigma first, so that more people will be able to cooperate, or more pharmacists in that sense. And after that, then maybe we can encourage more pharmacists to do this. Thank you.
Thanks, Prof. Would you look at that question around reimbursement? I'm not sure what the model is in your country, but maybe just a comment on that question.
Yeah, for the reimbursement in the Philippines, PEP can be free, but it can also be sold. Now, currently the treatment for the Philippines is actually TLD. We just shifted from LTE to TLD. And of course, for resistant strains, there are Alluvia and other drugs available, and these are all free from the government. And also the government allows for testing annually, and that is also for free. So the only problem in the Philippines is actually how to invite these people into testing and to put them in treatment. And once they are being put in treatment, if they need it, and once they are put on PrEP, if, for example, they are still negative, I guess the spike, not really a spike, because it's actually a definite growth in PLHIV in the Philippines. The number of PLHIV in the Philippines will just maybe go down, and we are actually hoping that will happen in the near future. Thank you.
Thank you very much for that. Let me throw the next question to Katrina and Hamish. And this question relates to where pharmacists probably have a major role to play, and that's related to our medicine expertise. So beyond the supply of HIV medication and the delivery of it, is there any other engagement taking place, like medicine reviews or individualized care around it in your country? And let me throw that first to Katrina, and then Hamish, if you can take it on after that. Katrina?
Yeah, thanks so much for that question. So, I mean, I think in addition to dispensing medication, pharmacy providers are often provided a number of counseling services, both formally and informally. And I think that's what we found by working with a lot of pharmacy providers in Kenya, is that often, clients are coming into retail pharmacies seeking sexual and reproductive health services with behaviors that are often associated with HIV risk, such as purchasing emergency contraception on a regular basis. So already a lot of pharmacy providers are providing counseling services. And I think enhancing that counseling with some formal training and training both on sort of helping pharmacists facilitate linkage to existing facility-based services, and then developing new models where pharmacy providers might be able to directly deliver PrEP and PrEP services, as well as HIV treatment services in the future, would be very exciting. A number of barriers that exist right now, though, especially in Kenya, as well as a number of other African countries. So I think a lot of the barriers are the barriers that we keep on hearing about, which is that a lot of these antiretroviral drugs are prescription-only medications. So trying to find sort of solutions or innovative, care pathways through which pharmacy providers might be able to prescribe some of these medications with proper training and remote clinician oversight, or using more mHealth interventions, such as telemedicine visits that might be facilitated at private pharmacies. or applications where people can take an HIV self-testing test home, test themselves, upload it, and then set up a remote consultation visit with a provider, and then return to the pharmacy. I think there's a lot of solutions for that in the future that are exciting. But there's going to be, in Kenya right now, we're sort of working on 3 different pathways to help enable some of these models of pharmacy-based PrEP delivery. So we're looking at the policy landscape and updating the National HIV Prevention and Treatment Guidelines to include private pharmacies as a place where HIV services could be delivered. We're also working on private sector engagement frameworks that can facilitate public-private partnerships, because right now a lot of the antiretroviral medications are public commodities that are often donated by large organizations like the Global Fund or other groups. So trying to figure out how you might be able to deliver public commodities in private settings. Additionally, we're looking at scope of practice for pharmacy providers and developing training tools and curriculum that could support delivering some of these antiretrovirals, which I know is happening as well in South Africa right now through the PMARC course. And then we're also looking at sort of delivery and regulation channels. So updating the Kenya essential medicines list so that ARVs could be delivered outside of healthcare facilities in settings like community pharmacies. And then also looking at some of these supply chain issues and giving pharmacies codes so that they can deliver public commodities, so that they can be listed as service delivery points as well for some of these antiretrovirals. So thank you.
Thanks, Hamish.
Yeah, so I suppose as a clinician and like a pharmacist, my primary role is to ensure that I suppose all medication prescribed to my clients is the most appropriate and without any contradictions. And this also involves, I suppose, educating our clients on their medications to actually ensure that they take them as prescribed. I mean, pharmacists are a really important member of the interdisciplinary or multidisciplinary team. And this is really due to the complexity of treatments for HIV infection, opportunistic infections as well, and other comorbidities, which I suppose are traditionally have been associated with aging. And this results in polypharmacy, adverse effects, and drug interactions. As a pharmacist, I actually really quite like drug interactions, but obviously my clients don't. And so as pharmacists, we have to identify them, any potential drug interactions, or toxicities, and actually make sure these are managed appropriately. With each of my clients, I try to obtain what we call in Australia a best possible medication history. And we do conduct medication reviews to try to ensure that our clients sort of have optimum outcomes. I ask all my clients at every visit, have you started taking any new prescription medications, any new vitamins, supplements, herbs, including herbal teas, something that your grandmother's given you, medicines that you bought in the pharmacy or the supermarket. If they're on a boosted regimen, I always ask about recreational drugs as well. Drug interactions are so rife with antiretrovirals, as we all know. With antiretrovirals as well, and other medications. I mean, we need to provide balanced advice on the adverse effects of the medication and their management. Fortunately, most of the, I suppose, modern antiretrovirals are very well tolerated, but I know around the world, many of the older regimens are still in use, including like efavirenz-based regimens. Even as a pharmacist, I think we can be involved in assisting in achieving some of the secondary goals of HIV treatment. And this includes promoting long-term adherence to therapy, which is actually really important, obviously, for clients' health. Long-term adherence reduces the risk of resistance developing and also reduces the risk of onward transmission of the virus. At times, I ask about my client's smoking status, and I'm very fortunate that I can provide free nicotine replacement therapy to my clients if they're wishing and choosing to stop smoking. Though I must say most of them are avid that they don't want to stop at this point in time. I think that's pretty common with the remaining 10, 12% of people who still smoke in Australia. But yeah, as pharmacists, we can do so much more than just sticking a label on a bottle and handing them out to the client. I think we're a really important part. We're really the front line of healthcare. We're the most accessible healthcare worker. And so people can come up to us and talk to us and ask us questions. And as long as they feel comfortable doing that. So we need to build really good relationships with our clients so they do feel comfortable. We need to treat them with respect, make sure everything we do with them is confidential, but also in some ways normalize HIV as well. So it is just like diabetes or hypertension. I actually say to my clients, you know what, you're actually better off being diagnosed with HIV today than you would be if you were diagnosed with diabetes. You've got better outcomes, health outcomes. So I don't know, there's a lot we can do.
Thanks for that, Hamish. What I'm going to do is, we've got another 11 minutes. There are two questions. I'm going to ask one of our coordinators, probably Ruben, to look at the issue of the connection between test and treat that Naeem is asking about. Ruben, if you can please comment on that. And then on Kasim's one around the injectables, and is particularly referring to the South African government. What I'm aware of is that it's going through its regulatory framework at the moment. So it's at the regulator SAPRA for approval. Once it is, I'm not sure what the cost model is going to be and whether the South African government can actually afford at whatever cost level it will come in. So I suspect it will be available in both the public and private sector, obviously in the public sector as a tender, and in the private sector at whatever that manufacturer, I think it's Johnson & Johnson, that would put it out in the market for. So let me go to Ruben to try and take Naeem's question on, and then I want to give the panel two questions to answer very quickly in the next 10 minutes. Ruben, are you there?
Yes, thank you, Sham. So for the connection between test and treat and counseling, so I'll just point out to the new resource that we have, because there's a lot of explanation in there. Then I'll also leave my email for any further explanation, so we don't also use the time and let our panelists give the last remarks as well.
Okay, thanks for that. So before I give the panel the very last question, my second last question, and I think it's related to a lot of information that has come out from the various countries around stigma, mental health, and maybe we can even connect this to the fact that we had this pandemic. HIV patients that were on treatment have been put on the back burner because of the focus around COVID. Maybe I'm going to start from the top again and go through the discussion very quickly around stigma and that. So Ali, let me start with you again. Can you comment on that, please?
Okay, first of all, COVID, like it's blessing for the HIV patient in terms of their drug delivery method. Like when everything was like shut down due to COVID-19, and the National AIDS Control Program of Pakistan starts sending through parcel, like medication, they send through parcel to the patient, their home. So this was a blessing in disguise for them. But there is still a lot of like stigma is associated with them. Even patients were like, they were not happy to receive through the parcels, because they say if someone sees them finding this parcel and they see that it's a HIV medication, their life will be ruined. Like their employers will not hire them for any future jobs. So still there is a lot of stigma, and I just quantified in my PhD study that more than 95% all HIV patients are going through this stigma and discrimination. So hopefully we can hire psychologists or pharmacists. They can work in collaboration, and they can reduce this stigma by teaching counseling to the patient and their family members and their friends. So thank you.
Thank you for that. Dr. Kruger?
Thank you so much. Stigma and discrimination are the main pandemic we face every day in Brazil and worldwide. I'm trying to explain, I think this way, HIV was the last pandemic we had in the last century, the biggest pandemic of the last century. And COVID-19 is the first, but not the only one, the first biggest pandemic of this century. But the stigma and discrimination pandemics is still there since then and nowadays as well. We need to struggle, we need to fight against stigma and discrimination pandemic, because it affects key populations, people living with HIV worldwide. And just a little comment on the interactions very quickly. For example, a lot of transgender people are not frightened to start PrEP or PEP or even the treatment because of the possible interactions between the hormone therapy and the ARVs, for example. And we need to spread this information. There is no huge information on important interactions between hormone therapy, either testosterone or estrogen. There's no huge potential interactions between that. And that's about stigma as well, because if you force transgender clients, for example, choose between the hormone therapy or the PrEP, PEP, or ARV, you are really being a not too good healthcare professional to them. So we need to fight against the stigma and discrimination pandemic, and we need to be a real reliable healthcare professionals to our clients in our daily practice.
Thank you very much. Dr. Harold Brunette, your final comments on that.
Yes, in France, during the pandemic, a circuit was set up for medicine delivered usually to the hospital to be delivered to the community pharmacies. And patients living with HIV or PrEP were able to see that the delivery of that treatment was going quite well and maintain this mode of dispensing. So I think overall we can say that the management of HIV positive or PrEP patients by pharmacists has improved, and the pandemic has helped in this. But we have yet a lot of things to do, and it's very important that pharmacists can guarantee confidentiality when providing treatment or advise his patients. And in France, thanks to the arrival of new mission, more and more community pharmacies have a space, a very special space of confidentiality. And there is still much work to be done to break down prejudices and view HIV infection as a chronic disease. I agree totally with Amish. A chronic disease like any other, such high blood pressure or diabetes. Because in France, the illness is still tainted by stigmatization and discrimination. So we have yet a work to do. CESFARM and the French Chamber of Pharmacists have a very active collaboration with AIDS Association, and it's a very good thing because I think that the care of these patients goes beyond the biomedical aspects and is done in a coordinated manner with all medical, social and associative actors.
Thank you, Prof.
Thank you.
Anghoy, your final remarks on those two subject matters and anything else that you might want to conclude on. Thanks.
Yeah. In my case, for the stigma, I'm going to touch on something that is actually growing in the Philippines. Now, stigma can also be internalized, and there are some parts of the Philippines, like for example, Cebu City, in which there is a growing 50%, well, generally in the whole world, there are 50% people that are also HIV positive and injecting drugs at the same time. So as I explained before, in the Philippines, there is not much structure for pharmacist volunteerism on HIV. So in my own practice, since I'm also credentialed for substance use interventions, so what I also do is incorporate that into my practice, in which the people who actually come to me for testing, I also do ASI and ASSIST, which are actually forms in drug use interventions. And per the scoring, I refer them also to the necessary centers for drug abuse, because there is actually a trend in the Philippines for not only in the growing number of people with HIV, but also those with HIV and at the same time uses drugs. So I think that we need to be innovative as pharmacists. If in my case, you don't have any basis for practice because they are still non-existent, maybe we can start by what we know, and maybe when there are guidelines, it would be, we could provide information for the development of such. Thank you very much for having me.
Thank you. Dr. Oddblood?
Yeah, so what I think is really exciting about community pharmacies, especially in a lot of low resource settings, is that community pharmacies are one of the first points that people access health services. Over 50% of people in low resource settings first go to community pharmacies for their healthcare needs. And then a lot of these healthcare needs include sexual and reproductive health services. And what we found through a lot of qualitative research is that people's preferences for community pharmacies have to do with the fact that they're ubiquitous, more convenient than a lot of public facilities. They're open for longer hours and also open on the weekends, so people can access services during times when facilities may be closed. Additionally, private pharmacies will often provide discrete services that can help clients maintain their privacy and confidentiality, especially compared to accessing HIV treatment and prevention services at public clinics, and specifically HIV clinics within public facilities. Additionally, based on clients' purchasing behaviors, pharmacists and pharmacy providers might be well positioned to identify clients that have behaviors associated with HIV risk. So if they're coming in purchasing emergency contraception, treatment for sexual transmitted infections, Viagra or other sexual performance enhancing drugs, that might be a great point of contact for the pharmacy providers to initiate conversations about HIV prevention services and treatment services, and link patients to existing care services, either if they can't provide them there at the pharmacies or at public facilities. And then finally, I think during COVID, there was a lot of need to decongest public facilities and innovate on delivery models that were more community focused or focused on self-care. So in Kenya and other settings, we saw a lot of multi-month dispensing that happened, as well as courier delivery models. And our research team is continuing to explore those, but I think private pharmacies, the delivery of HIV services at private pharmacies can also help decongest public facilities so that they are, free and available to address the next global pandemic. Thank you.
Thank you. Hamish, you got the last say.
Okay, so we're going back to stigma. Unfortunately, stigma is just so prevalent in the wider community, within people living with HIV, and also even within the LGBTQI community. I remember back in the early days of PrEP, which is not that long ago, people were labeled Truvada whores because they were owning their sexuality and their sex lives. And that's just horrific, people being stigmatized for that. We as clinicians and pharmacists, we need to ensure that we don't contribute to it. We need to treat our clients, our patients with respect, treat them as normal human beings, provide the best care we can, like we do for any other clients. That's all I've really got to say.
Thank you very much for that. So it leaves us 2 minutes over, and I just need a minute to conclude and wrap up. So the first thing is to tell you about the future digital events. If you can put up the next slide, thank you. And that is, if you can go onto events.fip.org, you will find future events, and even some of the presentations that have already been done, you can link up to that. Then finally, in my last slide, I want to say thank you to the office staff, Ruben and his team for assistance in putting it together, and Mila for all the supervision. And then to the presenters, thank you very much for making the time to share your knowledge today. It is really appreciated, and I'm sure people throughout the world have gained today, that have on the program have gained in your experience, and will take that back home. And then finally, to everyone that attended, there were large numbers today. Thank you for your time, and please take care and look after yourselves on this very special day. Thank you very much, everyone. Bye.